Thanks very much, Rob. Just checking in with everyone. How are you after the last session? I'll just drop my glasses as well. I am going to be talking about, well, it says here frameworks for intervention, but I've more grandiosely actually called my talk, Can We Prevent Schizophrenia? Hopefully I can move these slides forward. Should have worked this out before I got up here. So apologies, some people have heard a lot of this early stuff, but I will just make sure that we're all on the same page by going through the kind of background and what we already know. So what we already know is that the onset of schizophrenia is identified by the first episode of psychosis. So we've heard a lot about that in the last session. And we also know that the first episode of psychosis is generally preceded by a prodromal period. The prodrome is characterised by non-specific symptoms such as anxiety, depression, sleep disturbance, but also more proximal to the onset of psychosis. People generally experience what we call attenuated psychotic symptoms or subthreshold psychotic symptoms. So rather than hearing a full-blown voice, they might hear whispering or mumbling. Rather than feeling that people are out to get them, it might be more feeling very self-conscious. Is that person looking at me, and so on. And there's also experience of decline in functioning and role functioning during that prodromal period, which might be part of the symptoms that they're experiencing. So there's safety behaviours, for example, that Daniel Freeman was talking about. So this is a kind of a scheme of the first episode of psychosis. Again, should have worked this out beforehand, but yes, there's the pointer. So the prodromal period is the time when somebody first changes from their normal self, but before the onset of the first episode of psychosis. Then we have this episode of psychosis, which then various different outcomes following that. And the duration of untreated psychosis, so the time between the onset of psychosis and effective treatment, which is a very important variable in terms of prediction of outcome. But if we want to talk about can we prevent schizophrenia, the first issue was can we identify that prodrome prospectively? And so this research goes back to the 1990s. Some of you will remember the 1990s. It was a big age for fashion. The internet wasn't as great as it is now. So back in the 1990s, this is where the focus of my research, excuse me, at the time, was on can we identify that prodrome prospectively? And if it is possible to identify the prodrome prospectively, can we intervene to actually ameliorate the onset of psychosis, delay it, or even prevent it? And this is where the idea of the at-risk mental state came. So the idea was if we move, this animation took me longer than the rest of the talk. So if we move treatment, can we actually change the course and prevent that onset? But of course, the prodrome is a retrospective concept. You can only diagnose it after the onset of a first episode. So we had to coin some new terms. This is where we came up with the term of an at-risk mental state, or also known as the ultra-high risk period, the ultra-high risk criteria. So these were the criteria that I just made up, actually, this is likely to identify prospectively a prodrome. So it was age in adolescence and early adulthood, the chief risk age for a first episode of psychosis, and then to have either the subthreshold attenuated psychotic symptoms or a brief self-limiting episode of psychosis, or to have what we call state plus trait risk factors, so a family history of psychosis or the schizotypy that we heard about yesterday, plus a deterioration in functioning. So we developed these criteria. They're known by different terms, as I said. So at-risk mental states, usually the term in the UK. In Australia, often called ultra-high risk criteria. The Americans, of course, wanted to use a new term, so they call it the clinical high risk criteria. And the outcome from having these this at-risk mental state can be, of course, developing that first episode of psychosis, or it can be not developing that, and possibly even having those sub-threshold symptoms resolving, or what we call a false positive, which is where they would have developed a first episode psychosis, but for some intervention that prevented that. So they would genotypically, in their trait characteristics, it resemble somebody who did develop a first episode, but they didn't due to some intervention. And so when we talk about psychosis prospectively, as the outcome of interest, we have to also define what we mean by the first episode of psychosis, the psychosis threshold. It's an arbitrary line, just like a goal in football is an arbitrary line. The whole of the ball has to cross the whole of the line. What's this a picture of? So that's Courtney Vine scoring the winning penalty against France. And probably everybody can remember where they were when that happened. So the psychosis threshold that we defined, it was an arbitrary line, but the line corresponding to generally when you would consider treatment with antipsychotics for that person. So at least a week of psychotic symptoms that occur several times a week at that threshold level. And I'm not sure if Stephen Wood's here, but thanks to him for this slide of, okay, so we've defined this ultra high risk group. We've defined the outcome of interest as first episode of psychosis. Can we predict who will develop that first episode of psychosis? So the first study, and Chris Pantelis referred to this yesterday, a very high risk of psychosis from that initial study where we defined that at-risk group. So it was over 40% in 12 months. And this is actually the second study, which was 34% over 12 months. So very high risk of developing a first episode. And various reviews and meta-analyses have shown actually that rate's slightly lower than that. It's more like 22% risk in 1 year, 36% over 3 years. So although the transition rates, as we call them, were not as high as that at those initial studies, there still is a very high risk of developing a first episode of psychosis if somebody meets those ultra high risk criteria. We also know that the ultra high risk criteria are relatively specific for psychosis. So there are other outcomes other than psychosis, but they're relatively specific. And this has been shown by a study by Webb et al., which is from the United States. And what they found was that the, as they call them, the clinical high risk criteria, let's see if I can get this printing working again. So the clinical high risk criteria, and they compared those to people with mental health symptoms, help-seeking controls. And they found that the help-seeking controls had very low risk of psychosis. The clinical high-risk group had a very high rate of onset of psychosis, but there was no difference in terms of their prediction of other mental health syndromes. So I'm not sure if somebody's already drank from that. That's for me. Thanks. So there was no difference really in their prediction of non-psychotic disorders, showing that relative specificity. And that's basically what I just said. We also know that there are treatments available for that ultra high risk period. There's been meta-analyses that have shown that actually cognitive behavioural therapy can reduce the risk of first episode psychosis. Antipsychotics also have been shown to reduce that risk. But in more recent times, important to point out that they have not improved functioning. So although they can reduce the risk of the psychotic symptoms becoming threshold, they haven't reduced the risk of poor functioning. And more recently, some network meta-analyses where if you've got treatment A versus treatment B and you've got treatment B versus treatment C, through clever statistical means, people can compare treatment A with treatment C, even though they were never compared in the first place. So the people who've done network meta-analyses actually say that no treatment is better than any other in terms of reducing risk. But as I alluded to, and as you would have done by knowing simple maths, less than half of the people with that at-risk mental state, the ultra-high risk criteria, actually develop a first episode of psychosis. So what are the other outcomes? So psychosis is there, but also non-psychotic disorders, persistent attenuated symptoms. So if you assess them again, they would still meet that ultra-high risk criteria. Persistent negative symptoms, so avolition, amotivation, even diminished expression, for example. And some people remit, so their symptoms resolve. And there's, of course, overlap between those clinical syndromes. This is not drawn to scale, but just to illustrate that non-psychotic disorders, persistent attenuated symptoms, persistent negative symptoms can coexist with each other. And of course, people can remit. So in terms of can we predict outcomes, can we distinguish between who will develop psychosis and who will not, and who will develop other outcomes? So I'll just run you through some more recent research that we've been doing. So, oops, what happened there? I need to go. So how do I go back? The red one? The small red one. Okay. Thank you. So I know what I'm doing. I'm trying to push the pointer and pushing the forward button. So can we predict outcomes, distinguish who will develop psychosis and who won't? So I'll talk you through a recent individual patient data meta-analysis that we did, and also some work on trajectories rather than just looking at baseline and follow-up point. And there's also work on prediction of non-psychotic outcomes, which I actually don't have time to talk about. I know we've been running over time for a lot of these talks, so I don't wish to run over time. So this individual patient data meta-analysis, this was conducted with colleagues in Manchester and Liverpool in the UK. And what we included, as you see, ultra-high risk studies. They had to have been assessed with standardised instruments. So there's the comprehensive assessment of at-risk mental states instrument that I originally developed. There's the less good American adaptation of that, the structured clinical into the SIPS, can't remember what it stands for. And we looked at any prospective studies. So we included both randomised controlled trials and cohort studies. We did, doing an individual patient data meta-analysis is a bit of a pain in the neck because we need the individual data points from studies. So this involves contacting researchers and asking for their original data and trying to find those people. So this is an actual picture of me during that process. Anyway, to cut a long story short, this is the findings. So we found that higher age was associated with increased risk of transition. Poor functioning was also associated with a higher risk of transition, along with these attenuated psychotic symptoms of disorders of thought content, perceptual abnormalities, and disorganized speech. We found that negative symptoms predicted transition to psychosis. That's actually a novel finding that wasn't found before. And depression. We also found that antipsychotic medication was associated with increased risk of transition. And I'll talk about that in a moment. And participation in cognitive behavioural therapy was associated with decreased risk. This is a forest plot. I'm not going to read it out, obviously, but just so you can see the sort of effect sizes that we found. And the red writing is those factors that were associated with increased risk, which are the ones that I just read out. So as I said, that in this summary, just to mention the antipsychotic medications, a lot of times in the United States and also in South Korea, people were put on antipsychotics even though they weren't actually psychotic. So they had those attenuated psychotic symptoms. And it seems to be the people with the higher levels of psychotic symptoms were prescribed antipsychotics. So it was probably those people who were already at increased risk who were also prescribed antipsychotics, who were then developed the psychosis. And this is despite antipsychotics being shown to reduce risk in RCTs. Cognitive behavioural therapy, it seems that people who were able to engage with that CBT were possibly at lower risk, or it could be that the CBT actually has a protective effect. So from that work in the IPD, we then realised that we needed to test those prognostic factors in a prospective study. And develop a prognostic tool that kind of combines different risk and resilience factors. And we're doing that currently in England. We've got a multi-site study there. And actually about a month ago, we finally hit our target of number of participants, which was actually amazing. So we finally got over nearly 800 people in that study. There's also a very large study that's recently started called the AMP schizophrenia study. That's also a multi-site study that's doing, again, a cohort study looking at risk factors. We also need a better method of data sharing so that people don't tear their hair out. The next fairly new piece of research I'll show you is looking at trajectories. So again, not just looking at baseline and 12-month follow-up. So we looked at this trajectories in a number of different factors over time, over 15 years. And just to acknowledge Johanna Bayer, who's the one who did this research with me. This is Johanna here. This is Soxy, her cat. I'm Soxy's godmother. So the data set we used was collected between baseline, collected between 1993 and 2006, so over 400 individuals. We then followed them up and were able to follow up about 75% of those. And we then followed up the ones that had only recently come into the cohort. Oops. We managed to follow up 172 people again, so they've got at least 3 time points. And we had transition status, or whether they developed psychosis or not, through a combination of clinical and research data and administrative data. The method that we used, and when I say we, I mean Johanna, was this group-based trajectory modelling. Don't ask me to explain it, but she then developed a growth model so that we could look at trajectories over time. And that allows multiple different factors to be combined. So we looked at these variables: functioning, positive symptoms, negative symptoms, and depression. And this is the exciting finding. I hope that you can see that reasonably well. So when we tested the different models, the 5-factor model was found to be the best performing. And the 5 factors are across here. So we've got, well, the variables that we used are the rows, and the factors are the columns. So we looked at functioning, positive psychotic symptoms, negative psychotic symptoms, and depression. And the 5 groups, most people actually fell into what we call the getting better slowly group. So you can see in terms of their functioning that there's a gradual improvement in functioning, a gradual reduction in positive symptoms, also in negative symptoms and in depression. And that was 42.7% of the group. The next highest group also got better, but these were the getting better quickly group. And you can see a rapid improvement in functioning. rapid decrease in positive symptoms, negative symptoms, and depression. The next most prevalent group was the positive symptoms group. And you can see they're characterised by an increase in positive symptoms over time. Functioning remained relatively static, and a slight reduction in negative symptoms and depression. Negative symptoms more or less stable in that group. Then we've got the negative symptoms group, and they're characterised by baseline high negative symptoms that basically stay stable. Their depression also stays about stable, and their functioning declines. And interestingly, their positive symptoms also relatively go down. And the depression group was the smallest group, characterised by high levels of depression that persisted. Their negative symptoms were also persisted, and their functioning went down. So then we asked, are the groups valid? Is there any face validity to them? Do they kind of make sense? And do they have any predictive validity? And what we found is that there were gender differences. The Getting Better Quickly group had more women in it, and almost less in the negative symptoms group. So this is what we would expect. We know that negative symptoms tend to be higher in males. We also looked at the difference in cognitive data between the groups and found that the IQ of people in the Getting Better groups tended to be higher. And in fact, it was significantly higher in the Getting Better Quickly group compared to the depression group. But you can see that both of these fairly disabled groups had quite low, compared to the other groups, IQ at baseline. And also the negative symptoms group had a low verbal memory and processing speed, and the depression group also had low verbal memory and verbal fluency. In terms of predictive validity, so probably not unexpectedly, we found that the positive symptoms group had more transition to psychosis than would be expected. So that group, so we can detect trends early in people with the ultra-high risk state. We can predict from their early trends who are most likely to develop psychosis. Okay, so I've been talking about prediction of psychosis. Is it valid? From both the IPD and from that trajectory data from a number of different studies, but is that meaningful? Because we also know that the negative symptoms are also important. So is the psychosis threshold valid? We define the psychosis threshold by a change in positive symptoms. But again, the psychosis threshold is, as I said, just something that we made up. I could easily have put that down there, or I could have put it up there. And the ultra-high risk threshold also is, again, something that was just kind of made up. So is there any evidence that we've drawn the line in approximately the right places? So people who do develop psychosis are different from those who don't. Firstly, their functioning is worse. And we also have a number of different studies that compared controls to the ultra-high risk group to the schizophrenia or first episode group, and found higher rates of striatal dopamine, hippocampal volume, neurocognitive functioning. Chris Pantelis showed some of this yesterday. And this is Chris Pantelis' study, which is a landmark study that found that it was around the time of onset of psychosis, change from ultra-high risk to first episode, that we actually saw progressive grey matter loss, and that's been replicated in another couple of studies. And there's also some evidence of white matter loss around that time of onset of psychosis. And there's a number of different studies that show, again, that people who develop psychosis are different from the ultra-high risk group. I'm getting the wind up. So in other words, the arbitrary line has some meaning, so that it's associated with some meaningful outcomes. But not all first episode psychosis is schizophrenia. So if we prevent a first episode of psychosis, does that mean that we've actually prevented schizophrenia? What do we mean by schizophrenia anyway? So schizophrenia, it's a range of different syndromes, but generally characterised by a history of or current positive symptoms, negative symptoms, and cognitive functioning. But what we found is that some ultra-high risk individuals do transition but have a good outcome, and some people who don't transition have a poor outcome. And because I'm getting the wind up, I'll just quickly highlight this is the transition status, yes, no, 73 transitioned, and poor functioning status. Most people had actually good functioning at follow-up. And you can see actually that only half of those who had poor functioning at follow-up transitioned, and less than half of the people with transition developed poor functioning. So that's what all that's showing. I just already said that, so I'll rush through that. But also the people who did not develop psychosis but still had poor functioning, what's happening with these people? And it's basically not due to depression or anxiety. It's not due to the positive symptoms. It's not even due to baseline functioning. What it is due to is negative symptoms at baseline and a history of childhood trauma, which is what that says. There's been reviews of risk factors for poor social functioning. And again, they found it's not the positive symptoms or anxiety and depression, it's trauma, it's negative symptoms, it's neurocognitive impairment. So really the question is, are the people who don't develop psychosis but have poor functioning closer to that idea of schizophrenia than people who do develop psychosis but have good functioning? Which means that we may be looking at the wrong target. So we have been looking at so we can sort of think people with poor functioning, high positive symptoms, generally called schizophrenia. People with good functioning and positive symptoms are often called a benign schizotype. These are people with positive symptoms who might never come to clinical attention. People with who are below the psychosis threshold but poor functioning, sometimes called schizotaxia. And then we have that sort of benign group. And what we've been focusing here on the positive symptoms, but maybe we need to actually look at predictors of poor functioning and focus our attentions there. So as this sort of summary slide says, the ultra-high risk criteria predicts psychosis. In some individuals, this is associated with changes around progressive brain loss and neurocognitive functioning, but crossing the threshold is not associated with poor outcome in some people. Could it be that we have changed the outcome by intervening early? And there's some evidence for this, that people who were identified during the prodromal phase have better outcomes than if they were not, so that we might have changed that graph. Again, great animation. But also it might be that we've just identified people who would never have actually developed poor functioning. And another problem of just focusing on positive symptoms is that not all positive symptoms are the same. So there may be some that are indicative of a kind of neurodevelopmental schizophrenia. There might be some that are indicative of other disorders, but there might be some that are just benign, don't cause distress, don't come to clinical attention. So this is a study from Zammit et al., which showed that actually quite a lot of them resolve if compared to aged 18 to age 12. Some persist, but high resolution. So we need to find risk factors for persistence of psychotic symptoms. And it could be that actually, depending on the population that you're looking at, sorry, this is a very badly drawn diagram, that there'll be different proportions of those three different types of psychotic symptoms. So in the general population, you might have a very high level of people with non-distressing, non-clinical psychotic symptoms. In the first episode of Psychosis, you could well have a mixture of neurodevelopmental type psychotic symptoms, and those that are due to general vulnerability might be associated with anxiety and depression. And when you come to populations with chronic schizophrenia, probably most of those have that neurodevelopmental type. And what we're seeing in the ultra-high risk clinics is a combination of these red and blue groups. And how can we identify that neurodevelopmental subtype? Was mentioned yesterday, the polygenic risk for schizophrenia. And this has been shown to be linked to negative symptoms and anxiety, but interestingly not positive symptoms. And in another study, polygenic risk score was linked with low performance IQ. So this is like the third last slide. So just a word about pleiotropism and heterogeneity. What we see with the polygenic risk score for schizophrenia is it has a number of different outcomes: negative symptoms, cognitive deficits, anxiety, mood dysregulation, whereas psychotic-like experiences are heterogeneous. So they can be associated with schizophrenia, they can be associated with depression, with anxiety, with mood, with bipolar disorders, and so on. So in concluding, attempts to prevent schizophrenia, as I grandiosely called this talk, are not straightforward because the ultra-high risk group is heterogeneous. There's great variation even in those who develop psychosis. Interesting in the context of the talks from the last session, because not all people with first episode psychosis do go on to develop schizophrenia. So we need further refinement if we wish to predict schizophrenia. We need to continue to treat people who have symptoms. We need trials to reduce the risk of psychosis. We need trials that look at predictors and treatments for cognitive dysfunction and negative symptoms, and search for biomarkers so that we can differ those people. So the future directions are ideally, it's been mentioned before, to develop those biomarkers and then to target the mechanisms that we find in biomarkers. For example, inflammation and oxidative stress that was mentioned previously. So on that note, I'll conclude and just acknowledge many collaborators over the many years. Thank you.